Hello everyone, I recognise some familiar faces from across this week. So today we're going to think about autism and mental health and how mental health can affect people on the autistic spectrum. So we're going to think about how and why people with autism may be vulnerable to mental health problems such as depression, anxiety, OCD, eating disorders, and also misdiagnosis as well. So although it's a snapshot really of mental health in autism, there will be some questions at the end as well, but we're also going to be running a podcast. So if anyone has any questions that they would like answering, then is it to note the question down? Is that what we've decided to do? Yes, so if you'd like to, if you've got any questions, write it down and give it to each and any one of us who work here, and we can ensure that that's on the podcast as well. Okay. So autism and mental health. Research has found that 65% of adults with autism can experience mental health difficulties. And this includes things such as depression, anxiety, OCD and eating disorders. Now, why do you think that might be the case? Has anyone got any ideas?
You said the exhaustion of speaking with people
Yeah.
isolates. They need to separate themselves from people in order to recharge, but that can cause isolation.
Yeah, fantastic. Yeah. So can you hear that at the back? No? Okay. So we've just been talking about in terms of social exhaustion as well, and because there's so many different, we'll go on to that a little bit more, because when you're on the spectrum, you can struggle with social interaction and the various different layers of social interaction that can often lead to exhaustion. Does that kind of summarise? Yeah. Okay. Anyone else? Yeah, that's a really big one, isn't it, really? Yeah, you're right. We'll talk about that a little bit more. Yeah. Okay. That's great. Okay, so some of you might recognise our brain picture from across the week. But if we think about autism being neurodevelopmental disorder, so it's really about how your brain is shaped when you're on the spectrum. So if you compare a brain scan of someone with autism and compare a brain scan of someone without autism, there'll be very clear neurological differences. So if you see kind of these parts here, so if you see this part of the brain here, can actually be hyperdeveloped. So that's why often people on the spectrum may like kind of logic and have kind of a great logical and visual spatial ability. For example, puzzles, maps, buildings, awareness of buildings, things like that. This part of your brain as well also can be hyperdeveloped when you're on the spectrum, which means that that might lead to greater abilities in remembering facts. So if any of you on the spectrum or know someone on the spectrum, actually that's actually quite a common characteristic in actually knowing lots and lots of different facts about different things or details about different things. And having quite a good visual memory, so being able to remember what something looked like and where something might be positioned. So having a really kind of good eye for detail. However, the other side of the brain here can often be underdeveloped. So that's why often people might struggle with filtering out background, foreground noise, understanding social rules, and just even kind of the greater sense of kind of almost kind of societal constructs. Maybe kind of keeping things in mind short term. So what we know in terms of memory, people on the spectrum can often find that they have difficulties with short-term memory. Being flexible in terms of what we mean by that, in terms of changing tasks. So if you think of multitasking can often be quite a difficulty for someone on the spectrum. So actually doing one thing at a time might be actually someone's preferred way of organising their time. But if you think of how often workplaces are set up or educational establishments are set up, they're often it's often surrounding balancing different types of subjects or different types of tasks. So that's why many people on the spectrum can really struggle to balance all those different, or shifting attention to different tasks. Again, in terms of controlling overwhelming emotions, that can often be quite a difficulty, and planning an organisation. And what we call that, some people might have been around for the introduction to autism earlier in the week, but we call that executive functioning, and we'll go into a little bit more and touch on those things across today. And you're right, so in terms of triad of impairments, there's many reasons, lots of people might experience mental health problems just because actually how the kind of core difficulties of being on the spectrum. So we won't go into this in great detail, but if you think about someone's communication difficulties, so problems with social interaction. So we've discussed across the week, if you think of social interaction, and you think of the layers of social interaction, there's many different styles of, many different layers to it. So if you think of communicating with someone, you have to look at them, you have to position your body language to them, you have to think about your facial expressions, your tone of your voice, all those kind of parts to your communication, but also understand and mirror what that other person might be experiencing. That's even before you think about the content and whether the content is reciprocal or not, and how you build on that content. So again, that's probably one of the reasons why lots of people describe being almost peopled out and exhausted through social interaction. And many of us know when we're exhausted, actually our ability to even problem solve, even just to kind of stay on task, even to focus, to concentrate, even just actually think logically and rationally can often be difficult when we're all exhausted, can't it? And of course then difficulties with social imagination. So what we talked about earlier in the week is things like being able to put yourself in someone else's shoes, or hold something in mind when you're thinking about the consequences of problem solving. So that's a triad, but actually what we know now from lots of other research is then lots of people on the spectrum then have sensory sensitivities. So often being able to screen out things like background, foreground noise, sensitivities to light, sense of smell, taste, texture. Executive functioning, like we've been thinking about with the brain diagram. So just on a day-to-day basis of kind of just basic problem solving, memory, all of those executive things that often someone who's neurotypical takes for granted. And then there's even making sense of emotions. Actually, what do emotions mean? How do we actually make sense of them? How do we communicate them? So all of these things, someone on the spectrum will experience every single day, and that's without human experience. That's without kind of going through life, even before they even begin, really. So Tanto and Presswood said or found that individuals with autism are vulnerable to mental health symptoms such as anxiety and depression, especially in late adolescence and early adult life. Has anyone kind of got any ideas of why that might be? Especially late adolescence, early adulthood?
Something to do with the hormones?
Yeah, that can be. And understanding hormones, when you've then suddenly got this surge of hormones and trying to regulate emotions while, you're making sense of your hormones.
It's also the stage of life when you're trying to see where you fit with your friends, your peers, and
Yeah.
how developing how you are. So it's a very uncertain time anyway, isn't it?
Yes. So in terms of your identity, if you think it's a very transitional age, isn't it? There's lots of change that happen in your later teenage years into adulthood. There's often a lot of probably social expectations placed on you as well, isn't there? If you think of jobs, think of education, university. If you think of actually socialising, there's very kind of clear differences between childhood and adulthood. And we will discuss kind of more in detail about those things as well. So if we take depression, a study by Tantum said that depression is common in individuals on the autistic spectrum, 1 in 15. And it's important to remember that depression in people with autism might have a different root cause. Because like some of the things that you've talked about, actually for someone with autism they may experience the will very differently than someone who's neurotypical. So for example, a growing awareness of their condition. So as a teenager, I've worked with one particular guy recently who talks about his teenage years and said that he was aware that he was on the spectrum because he couldn't understand what to do in a friendship or what was required in a friendship or dating. That's a whole kind of almost kind of different ball game altogether, isn't it? You know, as a teenager, never mind then if you're on the spectrum as well. And this kind of growing awareness actually that they might be different than their kind of peer group who hasn't got autism. And it is really kind of almost kind of this kind of sense of being different that many people on the spectrum can struggle with, especially when we've worked with individuals in early adulthood as well. And almost kind of grieving for, and almost feeling like a sense of loss compared to their peers. One particular guy at the moment who I am working with is in his late teens, and he said, you know, I want to do the things that my friends are doing, but I really find that really difficult because of all my difficulties, but I still want to do them. So that's going to be really frustrating and really upsetting for someone on the spectrum, especially when actually they want to do those particular things. And picking up from what this lady said, often we can find that sometimes society is not very kind to people who may relate to the world differently than someone who is neurotypical. So lots of people could either be bullied or victimised because of their differences as well. And of course that's going to have a natural reaction on the person's that's going to really affect that person's self-esteem and their confidence. It may be that they may struggle to take part in social activities successfully. So again, I work with one guy at university at the moment who says, I want to socialise. Because what we know from autism, it's a myth that lots of people on the spectrum, that actually they don't want friends. We know that's a myth. Lots of people on the spectrum want to socialise, but actually he really, really struggles to know what to do in social situations. He's got quite heightened sensory sensitivities, so a lot of students spend time in the pub. You know, lots of music, there's lots of people around, and it's really, really difficult for him. He still wants to socialise. It could be that people also may have difficulties forming and maintaining a relationship. So if we think of how difficult it might be to have a conversation, that's a conversation. What about actually being able to have a relationship and actually understand the rules and all the technicalities of having a relationship and maintaining a friendship? Can really, really cause a lot of confusion for someone on the spectrum, which can then lead them to be more vulnerable to depression. It might be as well that some people with autism have difficulty making sense and interpreting these emotions. Now we know lots of people who are neurotypical might struggle with understanding their emotions and making sense of their emotions. So combine that also with being on the spectrum, where actually being able to make sense of emotions, even to be able to spot it. So if you think of facial expressions, often we can decipher what someone, or make a guess about what someone might be feeling through their facial expressions. What if you can't actually gauge that? You know, and you can't actually gauge how another person feels, and that can actually, and also yourself as well, and be able to understand this feeling and make sense of that feeling within yourself as well. But it's important to note that many people present differently than neurotypical people when depressed. So always kind of bear that in mind as well. You might not see the usual presentation of what depression would normally look like with someone who's neurotypical. So this actually poses quite a bit of a dilemma as a clinician, really, working with people on the spectrum, especially if the clinician doesn't have experience of working with people with autism, because normally our standardised clinical diagnostic tools are they're more reliable for people who are neurotypical and the classic presentations of depression. So it's really important to be able to assess the person in the context of their autism. So kind of you look at any kind of gradual sudden changes in that person's behaviour. So for example, that person might always be socially isolated because that's what they prefer to do. That doesn't mean they're depressed, but actually is there any changes in that? Yeah, so suddenly, such as, you know, the changes in kind of behaviour or sleep pattern, or just even kind of general how they kind of communicating emotionally as well. Now, in terms of treatment for depression, medications used in general practice can be prescribed for people on the spectrum, and this is not my particular area, and that's something our psychiatrist area. However, what we do is follow NICE guidelines. So what the NICE guidelines say about medication and supporting someone with medication who is on the autistic spectrum is actually don't use medication to treat the core symptoms of autism. So what we mean by the core symptoms is a triad of impairments, because actually we know that person will always have those difficulties. So often, now they're now with NICE guidelines, and often practitioners now will talk to individuals about that, and in terms of kind of managing expectations of where or how far medication can go. But it's really crucial to identify the cause of depression to determine the best treatment model, because it may be that there may be other things that might help to alleviate that person's depression. For example, if someone is feeling quite lonely and they're feeling quite depressed because they don't know how to meet and maintain friendships and relationships, maybe a social skill program might be a good opportunity to support that person through understanding social rules, and or even how to the basic rules around making friends and maintaining friendships and relationships. And that's something that we've started to do over at the Tuke Centre. We now run a 6-month program, social skills program for people on the spectrum, and it's the only social skills program that's accredited, or actually it's in the NICE guidelines as well. Again, specialist therapy. So maybe someone might benefit from some specialist psychological therapy with a practitioner who has experience of the spectrum, to be able to make sense of that person's feeling, but also around knowing more about their diagnosis and thinking about how their diagnosis might affect their self-identity, and also leaning towards kind of a self-acceptance. Because we all know that if we accept ourselves, that's going to generally make us feel much better about who we are as well. Now, what we know from the evidence base and also from NICE guidelines is CBT can be really, really helpful for people on the spectrum. It can really help to manage low mood and negative automatic thoughts, especially if they're kind of associated with the individual's belief system. So lots of people who we work with might think, well, it's my fault, or feel what's the point, or I feel a failure. So it's been able to help the person to manage the negative associations that they might be experiencing. Has anyone got any questions about depression? Okay, so anxiety. Now, anxiety is really, really common for people on the spectrum. Now, we know that lots of people on the spectrum are prone to anxiety and will always struggle with anxiety. This particular research paper found that 84.1% of people on the spectrum met the full criteria for at least one anxiety disorder, which is huge, isn't it? Really. So some of these anxiety disorders may be things like panic, phobias, OCD, generalized anxiety. So in terms of the triggers might include a consequence of the social demands placed on that person. So if you think of the university life, or you think of friendships, often there might be quite a lot of social demands placed on the person. The person might really then struggle to make sense of and understand and find confusing. So actually that might make them quite anxious, especially in social situations. So social anxiety can be quite common. Changes to daily routine. Change, again, is really can be really anxiety provoking for someone on the spectrum. So even minor changes to daily routines can really affect how someone perceives their day, and also being able to problem solve. Because we talked about this earlier on in the week, but if you imagine, if you think of your think about things kind of cognitively. Someone who's neurotypical might think, okay, if I'm late for the bus, it's okay, I can do X, Y, and Z. But to do that requires executive functioning. So you need to be able to keep that problem online, be able to manipulate the information, such as, well, I can get the number 2 bus, or I can just walk to this particular bus stop, or I could call my boss to let them know that I'm late. That requires quite a lot of execution, doesn't it? And what we know in terms of people on the spectrum, that their executive function is often impaired. So actually one slight change of that daily routine can really, really stress someone with autism. Because actually then how can I get around this? How can I think straight? But even before, if you think even without the spectrum, what we know from anxiety as well, often if we are anxious, what happens is our frontal temporal lobes almost go on hold, because actually we're almost in fight or flight mode. And if we're in fight or flight mode, often we can't actually concentrate, we can't think straight. So you've not only got a biological process happening here, but you've also got the neurodevelopmental process running alongside of that. Sensory sensitivities is something that a lot of people on the spectrum really struggle with. So if someone who has sensory sensitivity, say with light or noise, and they are in an environment where there's lots of people, I think of a supermarket, or if you think of a shopping centre, you've got a lot of input there, haven't you? You've got all the artificial light, you've got all the hustle and bustle, you've got all the people charging on by and brushing past you. You've got a lot of sensory stimuli there to process. So that can cause quite a lot of anxiety as well, especially if you feel overloaded by all of this different sensory information. And it links in with changes. But this feeling, often, if many of you who are on the spectrum or who know someone on the spectrum, actually not knowing what to expect can cause a lot of distress and a lot of anxiety. Because again, coming back to that executive functioning, actually knowing what to expect is important, because it's the idea of imagining what could be might be a difficulty. So actually lots of people will often say to us, can you let me know what to expect? So we're in a social skills program at the moment, and what we did was we actually sent out as much information as possible out. We invited the person in beforehand, before the group, so they could see where they were going to have the group, actually meet the facilitator. All of those things are really important, so that person could then hold in mind what to expect. So that would alleviate some of the anxiety on the day. So Atwood states that many young people with autism report intense feeling of anxiety, which may reach a level that requires intervention. Now, what we know from in terms of how our mental health systems are set up, often it's very, very hard to get support for someone on the spectrum. But now using the new the autism strategy that's been revised, and also the NICE guidelines, we can now create more of a case for someone on the spectrum to actually receive specialist psychological therapy. So, how does the individual often cope with anxiety? Okay, so one way of coping with their anxiety level is often it could be to retreat into their particular interest, which some of you might have observed or have experienced, or repetitive behaviour might increase as well. So maybe the need to know what to expect more, or doing particular things over and over and over again. And if you ask someone on the spectrum, what they will normally say is because that actually creates sameness and predictability in their life. But this level of preoccupation can often determine that person's level of anxiety. So that's why it's always important to think about what that person is like on a day-to-day basis normally, but then also if there's been any changes. And if there's been any changes, because often we know that lots of people on the spectrum love to be preoccupied by their interests, and love to we're obviously quite engaged in quite a lot of repetitive behaviour. But is it out of character for that person? So always think of that, because actually that can be quite characteristic for a lot of people, but if there are any changes. Okay, so anxiety can also increase rigidity in thought processes as well. So someone might be more insistent on doing things in a particular way. So, and what we've experienced often is that can cause someone quite a lot of distress then if they can't actually do the routines in the same way, in the same order. Which again, in families, can often put a lot of pressures then on families, because families may sometimes maybe not understand the importance of that. So a lot of the work that we do is educating families as well, and support or involve the family in the support that the person needs. Okay. So, autism or OCD? Has anyone ever kind of come across this particular kind of debate? Yeah? Okay, so sometimes when people come to us, they may have had a diagnosis of OCD. And that might be because the clinician who's worked with them has been probably observed their, repetitive behaviour. Yeah, and doing things in a certain way. But what's different about that in someone with autism is often it's actually a sense that it helps that person to feel better, yeah, in the way that they, actually feel to be able to predict sameness, predictability. But the difference is there's no cognition attached, like often with OCD. So if you think of the main kind of, the kind of usual presentation of your OCD, is often there's a fear behind it, there's a cognition behind it. Okay, if I don't do this, then something bad's going to happen. Yeah, so the cognition of fear. But often people on the spectrum, that cognition's not there. Yeah, because it's normally just repetitiveness, because they actually quite like doing things in a particular kind of order. So that's why often some people get misdiagnosed with OCD. So it's always good to question if there's a cognition kind of attached. But absolutely, I have worked with people who also do have OCD as well as having autism as well. But it's always good to kind of check that out. But yes, often the kind of typical obsessive action is often seen by someone who's neurotypical as OCD. But actually lots of people with autism say, well actually no, that's actually completely different. This just, this is something that I do all day because I like it, I find it sensory stimulating. Or it's actually, I just like it because it helps me to just predict what's coming next. And actually, the rule of thumb with us really, how we think, if it's not actually taking over that person's quality of life, then why even think about that really? Why change that just to actually, for someone to conform in a neurotypical world? Okay. So in terms of the treatment of anxiety disorder, it's again like depression, it's really crucial to identify the cause of anxiety. And that should be done by careful monitoring of the antecedents that might increase anxiety. So what happens beforehand? So it might be that the person doesn't have a structure or routine. So because they don't know what to expect, they may have elevated periods of anxiety. So always kind of ask the question, what's your structure like? Have you got any kind of routines? That might be something that might need to be implemented. Is it sensory based? So if someone's kind of, you think of, they've moved into a house where there's lots of other people who are really noisy, or might have a particular sound in their bedroom that's actually really, really quite irritating. I worked with one person who said he moved into one house and they had wooden floorboards. And there was a particular person who, I think, upstairs with wooden floorboards, and he could hear every single step, and it really irritated him, absolutely irritated him. He could not sleep, he was just in a really bad way, because again, for him, he couldn't screen that out, and he couldn't kind of focus on and filter that information out and focus on anything else. So it really did affect his quality of life. So don't underestimate in terms of someone's sensory sensitivity. Not knowing what to expect. So often that can be a big trigger. So actually communications, that's something as professionals or as family members that we can do. So we can actually get better at communicating what the person can expect. So that's why in terms of the service that we deliver at the Tuke Centre, it's important that we try and communicate as much as possible about what the person can expect, because we know that might minimise some anxiety. And again, if it's in terms of there's lots of social demands placed on that person, actually, what could we do about that? Is there something that we could support that person with? So for example, in terms of the treatment options, you might think of a sensory assessment. Yeah, so there are some specialist OTs now and clinicians that deliver administer sensory assessments. So we know in terms of what the person's sensory profile is like, and that can really help then in terms to help the workplace or educational establishments and families to make the reasonable adjustments they can to the person's immediate environment, because someone's sensory sensitivity will never go away. It will always be there. Again, modified CBT is really, really helpful, because CBT, cognitive behavioural therapy, is really good for someone on the spectrum because it's logical, it's black and white, there's a structure to it, there's the rule pattern to it. It's a perfect mantra, really, for someone on the autistic spectrum to follow. But again, it's important that it's modified to the person's difficulties. And what we find in the work that we do at the Tuke Centre is actually mindfulness can be incredibly useful for someone on the spectrum, especially when they have heightened periods of anxiety. And this is a particular, it's a therapy, dialectic behavioural therapy has been around for a while, but we are finding that DBT can be really, really good for someone on the spectrum when they've got anxiety, especially around being able to manage overwhelming emotions and how to even to make sense of their emotions. Because there's a compartment in the DBT program called emotional regulation, that goes into detail about how that person can make sense of their own emotions, and also how they can communicate their emotions. It could be working with the workplace, university, family to make reasonable adjustments, or just even simply just offering some psychoeducation to people around them, just around the things that other people can do. Because there's many things as neurotypical people we can do for someone who is on the spectrum that actually can alleviate someone's distress. Now, this is a little bit, we did a little bit more, a fuller seminar on eating disorders on last Friday. So if any of you are interested in kind of a broader, longer presentation on eating disorders, because this is a particular big area that we've found now within the autism spectrum, we are going to be having, we've got the slides that we're going to be emailing around to everyone at the end of Autism Week, but also I think, have we got we've got the video as well of it as well, haven't we, that you'll be able to access online. Now, what we know from the research is 20% of people with autism can have an eating disorder. So, you know, if you think of lots of reasons why kind of this could be. So, it's always important to check in with kind of a parent with someone with autism around their kind of ritualistic behaviour around food, maybe when there was a child. Because it may be that that person might have preferred to eat certain textures, certain tastes, and that gives you a lot of information about that person, especially when it might come down to people's sensory sensitivities. It might be that person might treat their weight as a special interest. So I worked with one person and she said she remembers the day, I think she was about 7 years old. She picked up the Haribo packet and she saw that there was a nutritional chart on the back, and she thought, wow, how fascinating. So that became a special interest. From then on, that was her special interest. She wanted to know everything about kind of the kind of nutritional kind of parts to this. But actually, to the point then, she met the criteria for an eating disorder in terms of her BMI. Because she was obsessed with the science of calories, the science of charts and tables, which kind of makes sense really, doesn't it? Yeah. And also what we know, lots of people on the spectrum really do struggle with perfectionism. And in terms of body image, if that translates to your body image and you have kind of this huge attention to detail, that can also be quite problematic. So coming back to the sensory impact, there's lots of things. If you think of food, you've got your texture, you've got your smell, you've got your taste. If you pick up something that's off, you're not going to eat it, are you? Because it's just really overpowering. So imagine if you had a really, really high sense of smell, then that's going to really lots of things are going to be off-putting around you. So we had one particular patient here at the retreat who there was a fruit bowl that was often there at meal times, and that person couldn't eat their dinner because of this fruit bowl in the middle. Because the fruit bowl was that overpowering that they just couldn't even think about eating anything else. And of course, someone who doesn't know much about autism might think that person, oh, they're restricting, or they're doing this for another kind of reason. They're not eating for other reasons. But actually, that person wasn't eating because of their sensory sensitivity, not because it was for any other reason whatsoever that might have been associated with mental health. It was because of their sensory sensitivity. But again, it can be interpreted very differently. Always check as well for intolerances, because what we do now, know more and more from the research now, that often lots of people with autism can struggle with intolerances as well, and have quite a lot of undiagnosed food allergies. So it's always important to think about, are you sensitive to wheat gluten casein? Because we know that can often be a difficulty. Now, there is a debate now in the autism world around, is it an eating disorder or is it disordered eating? Yeah. Okay, so actually, because if you think of neurotypically, we think that people should have a variety of food, that they should eat 5 a day, should have all different textures and tastes and smells. But actually, if that person really likes that particular food type, if they find it really, really hard to digest other textures, it can actually be more aversive to actually expect that person then should engage in what we think as society they should eat. So, of course, if that is affecting that person's weight, then it's important that you bring in a dietitian, a specialist dietitian, who can then look at what their sensitivities are not, or can look what the sensitivities are and what things they can eat, and maybe work around that person's sensory sensitivities. But it's always important to always bear that in mind, because actually treatment can actually become quite aversive. Yeah. So always try to identify the cause behind an eating disorder, because there can be things that can help. So things like specialist therapy. It can be psychoeducation, like that particular person who I worked with, and it became their special interest. It became so narrow that they was only thinking about calories, not actually about nutrition. So once we gave that person information about nutrition, then actually their special interest swaps related to nutrition, but then automatically that had a huge impact on their body shape and their BMI. Check out their senses, so by a sensory assessment. And also it may be that if they have got a particular fixated interest in particular science of calories, maybe can occupational help them to explore other types of interests that might actually be a little bit more healthier for that person. And again, DBT is a really, really good therapy for someone with an eating disorder as well, especially if someone on the spectrum might be using, maybe restricting, so then they know what to expect. Or it's a way of controlling their anxiety. So DBT can give someone other ways of coping if it is around managing their emotion. Now, many of you might be aware, misdiagnosis is really, really common with people on the spectrum. So there's a huge debate between psychosis and autism. So when people often come to us, they have a collection of different diagnoses under their belt, whether it's personality disorder, schizophrenia, all different things have been suggested. So if we think about psychosis, for example, if you think of someone on the spectrum who is very literal, so if you ask someone on the spectrum, do you hear voices? Yeah?
Not personally.
Yeah, but literally, if you took that literally, you hear voices? Of course we do, don't we? You can hear my voice. Yeah? So again, the types of questions often we ask as clinicians can sometimes be taken very differently, and actually in terms of literally. And always be careful the type of questions we ask individuals with autism. Also someone's sensory experiences. Now, I worked with one particular lady who saw, when she thought about a memory, she thought about it almost as a camera reel. So she got really, she could smell, see, almost kind of get the sense that it was still happening when, which is actually fantastic because it's your memory comes alive. But if you imagine that's going on, kind of you've got a thing and you think, oh wow, that's brilliant, that's amazing. But then you're having a conversation and you're kind of like, because it feels so real, you might look preoccupied. Yeah, so someone might say, a clinician might say, yeah, and they was preoccupied. Da, 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 da. Well, actually, no, they're not preoccupied. It's actually maybe because they've got very, very powerful associative memories in terms of their sensory experiences. And also as well, it may be that someone with autism might see the world kind of differently. Yeah, and again, that might be different than someone who is neurotypical. So in terms of how they understand different concepts. But in terms of the sensory experiences, I think it's really, really, I find it fascinating because one particular gentleman talked about, I think a psychiatrist came to his house, and he was saying, a dog won't stop barking, blooming dog. And the psychiatrist said, I can't hear no dog. What dog? This person must be having auditory hallucinations. When actually, what this person, he actually could hear the dog. He had really heightened auditory sensors. So he could hear sounds from miles and miles away. But for someone who didn't have kind of that ability, then that would actually come across as maybe, maybe they're having an auditory hallucination here. But there is no evidence that people with autism are more likely to, and anyone else, to develop schizophrenia. So obviously people can still have psychosis as well, but in terms of, there's no link that someone is more likely to have psychosis than someone who is not. But it's always good to think about, is it psychosis or is it autism? So in conclusion, really, in treating mental health, it's important that, especially if that someone goes to see the health professional, that they have an awareness of autism because of all the things that we talked about. Because often, if you think of someone who's neurotypical and the things that might cause that person to feel depressed, anxious, that person then might require a different style of treatment than someone actually on the spectrum who may be struggling with all the things that we talked about today. So it's really important that the professional involved is fully involved about, or informed about that person's communication methods, both non-verbal and verbal as well, but also what actually that person is like on a day-to-day basis. Because actually that might be perfectly normal for that person's normal presentation. But also it's always appropriate to speak to parents and carers as well when you're working with that particular person, to make sure the information is reliable. Because often parents can and family members can say to you, no, that's actually fine. No, that's what he does all the time. That doesn't mean he's mentally ill. Or actually, no, this is happening, he's more fixated with this particular thing, or he's engaging more in his routines, and normally this is a sign that he's struggling with something else. And because he can't actually tell me, because he can't make sense of it, he might show me in a different way. But don't feel afraid to ask the health professional about their experience of autism. And the nice guidelines are there for people on the spectrum, and also for families and carers, not just for clinicians. So if you wanted information about the types of treatment that have kind of the most research reliability, or also what should be expected for someone to be able to have, then the nice guidelines are a really good source of evidence. And also there's now becoming more of an evidence base behind the different styles of therapy that are really useful. And that's something that we're really passionate about at the Tuke Centre, is actually being able to add to the evidence base, so we can actually almost kind of either whether it's conduct research, and Fran's helping us at the moment with looking at a research study into how effective DBT is for someone on the spectrum, But always follow the evidence, because there's more and more and more research now that's coming out to say there's lots of different therapies, modified therapies, that can help some on the spectrum. Because there has been a culture where, oh no, just because you're on the spectrum, that doesn't mean that you won't be able to access therapy. It won't work. What we do know as clinicians is therapy is very useful. Very, very useful. As a clinician, it's us that needs to modify our approach. We need to think about the right approach for the client. Okay, so just a little bit about the Tuke Centre. In terms of the Tuke Centre, we offer specialist psychological therapy at the Tuke Centre. We offer psychiatry. We offer diagnostic assessments, but also post-diagnostic support to individuals and families. We've also just started the Socialise programme, so the 6-month skill-based intervention. So that's kind of a really exciting time. And we do have access to occupational therapy as well. Okay, so a little bit of a kind of an overview and a snapshot of mental health.